Good evening, friends. We'll take the two cases that we had posted earlier for you, and I'm very glad to say that most of you answered it correctly. I'm just going to add a few things to what exactly was the case about and how should you approach it. So this was a 65-year-old gentleman who actually we didn't mention. You need to ask about, there are some questions you can ask. Is he a tobacco chewer or not? So he was a tobacco chewer. So there is an abuse of tobacco. There is a significance as to why we should ask this tobacco chewer. Whether he's taking it in a smoked form or smokeless form, both are harmful. How are they harmful? We'll just discuss. He's presented with a growth at the right angle of mouth. And what does that mean? It's only confined to that angle. So you naturally need to also look at the picture carefully. You can see that the mouth opening is adequate. So how much is a normal or adequate mouth opening? It's not 3 fingers, which you will read in many books. There's nothing like fingers, because when you're saying fingers, it is very subjective, because individuals will have different sizes of the fingers. So it's 3 centimeters. And this 3 centimeters is what? The gap between the 2 lips? No. It's between the incisors. Right. So you can see that the mouth opening is adequate, which indicates what? If the mouth opening is not adequate, then we suspect that there are other features associated. You know, this is one region of cancers. So we have not come there, but I just thought, since it will be pertinent here, you must take the history of tobacco abuse very extensively. Ask questions. Do you smoke? How often do you smoke? And then you know about the smoke years, pack years, sorry. And then if he's taking BD or he's doing reverse smoking, the incidence can be further higher. Now suppose he's taking tobacco in a smokeless form, which means he's chewing it. Now remember, the moment he says I'm chewing tobacco, it can again be in various forms. He could be taking it as pan, where he'll chew and spit it out, or he could be taking it as a quid, which is very important. And the Hindi word for quid is kenny. So they put a pack under the, in the gingivobuccal sulcus on lateral sides or in front, commonly in the lateral side, and that's why the lateral sulcus cancer is also called as the typical Indian oral cancer. So which one is an Indian oral cancer? Classical Indian oral cancer is lateral sulcus cancer. Now when we talk about what more to ask in history in this patient, naturally you need to find out history based on understanding of this disease. Now this is one cancer where there are precancers. I'm not talking about predisposing factors. They are precancers which are known to have occurred. They are known to be associated with cancers, because invariably they change into cancer, like leukoplakia, erythroplakia, that is white patch, red patch, melanoplakia, which is black patch. Black patch is very easily seen. In a lot of normal individuals also you may find these patches. But if you're asked a question, which of these 3 is most likely to change into cancer, it is the erythroplakia, not the leukoplakia. Leukos means white, erythros means red. Melano is of course black. Now, is there anything worse than that in terms of the precancerous condition? Yes. Any of these these entities existing together. So, leukoerythroplakia or vice versa, this is the worst. So, if it is 1 plus, this is 2 plus, 1 plus, and actually 3 plus contribution that you can look at. That's what you need to understand. So take that history carefully and must take that history in details. So you'll find out, did you have a patch in the oral cavity? Did you have any, we have not mentioned about, these are the patches only. Submucous fibrosis. As the term indicates, submucous, under the mucosa, there is some bit of fibrosis that starts happening, which is like a sheet spreading across. And you will commonly find it at the angles of the mouth. This predisposes to cancer. And then, of course, you have candida. And of course, today we know one of the very important causes is HPV, which is not a pre-cancer. It leads to cancer. Now, if you were to look at the various possibilities of an individual developing cancer and these predisposing conditions, you can have some bit of understanding from what we have just discussed. So I mentioned about HPV here, then leukoerythroplakia and erythroplakia. Take that history. Now, what is the relevance of history of taking tobacco? How does tobacco contribute to any oral cancer? This is a commonly asked question. Why oral cancer, any head and neck cancer, or the cancer of the aerodigestive tract? Remember, tobacco, you read in the book directly, it doesn't directly by irritation cause anything. Tobacco has a product that is nicotine, which is what you know is these people consume. Their addiction is to nicotine actually. Now nicotine changes into nitrosamines. How does that happen? The action of bacteria in the oral cavity. So if the hygiene is poor and there is nicotine, the chances are that nitrosamines will form and they cause cancer. So if you're looking at what would increase the risk, one is the contact time. If the contact time is more, there is more time for the nicotine or the nitrosamines to cause that damage. We know nitrosamines are cancerous anywhere in the body, they are carcinogenic. So if the person puts a quid and keeps it overnight in the lateral sulcus, and his hygiene is already poor, so there are bacteria, the two combined together would increase the risk. And he also taught that alcohol potentiates the carcinogenic effect of nicotine. This is like if they're taken together, what nicotine does, what alcohol does is that it takes away the protective effect of the mucosa. I'll touch this even for HPV. How does HPV increase the risk? You know what does HPV do? HPV also works on the mismatch repair genes. What is a mismatch repair gene? These are tumor suppressor genes that work on any mismatch happening. If they have a mutation, cancers happen. And this entire thing is called as microsatellite instability or MSI, which is also seen in colorectal cancers, many places. Basically, it's related to the mismatch repair genes. So if you are looking at various factors, HPV is one group. Now, HPV produces cancers at many places in the body. By its action, it produces a warty growth, classically. And remember, at the angle of the mouth, this is a common growth. And how does HPV spread? Don't use the term these days. People more fond of calling history of contact. This is no longer a valid term. The terminology is history of high risk behavior, which means many things. Multiple sexual partners, IV drug abuse, etc., abnormal sexual habits, they all contribute. And this whole thing put together is responsible for these cancers happening. I have given you this background, not that it was directly relevant. What next in a case, we'll just come to that. Take this history. This entire history, I mean, there's no end to what all you can ask, but these are important aspects to take the history of. And also, take the family history. Not many oral cancers are familiar, but do take that history. Now in this case, we have the growth at the angle of the mouth. So when you will examine, you will look for any change in facial symmetry, as we teach often, and look for this inter-incisor distance. It should be more than 3 centimeters, incisors I'm talking, anywhere, which would be a good enough opening. Now a word about restricted mouth opening. Then I'll come to the workup, don't worry about it. Restricted mouth opening will be less than 3 centimeters inter-incisor distance. It can be painful or painless. Please understand this. When it is painful, it's called trismus. Very loosely the term is used. Inability to open the mouth is not trismus. That will be called inability to open the mouth. And the most common cause of trismus that you will find in association with cancers is involvement of masseter or pterygoids, which actually would mean that cancer has gone backwards and into the infratemporal fossa, so that makes it non-resectable. It is not something you can operate because the other end of the other end is attached to the skull base. Now, that's non-resectable. Painless can be due to many reasons, like submucous fibrosis. There are many benign causes of trismus also. It's not always cancer, benign. They include peritonsillar abscess or quinsy, tetanus, and eruption of the molar, wisdom tooth. The benign causes and malignant causes. So take that history, that's what I wanted to say. Now what do you do when you have a lesion there? You must think of this as a malignant growth because you can see that it is warty, but in a 65-year-old gentleman who is a tobacco abuser with an ulcero-proliferative growth, you would think of malignancy. So what do you do? Investigations to confirm the diagnosis, stage the disease, treat, and to support in between. Now what do you do to confirm the diagnosis of cancer? You must take a biopsy. And I already taught about biopsy, edge biopsy, which is a type of incisional biopsy. And why should we take it from the edge? Like I will show you in this picture. Where would I take it from? I'll take it from somewhere here. Here. Not from the necrotic part, because one, there is maximum proliferative activity happening at the edge. And you also get some normal tissue, especially for the MBBS students. This is not a bad answer to give. Many times the examiner is focused on this part. normal tissue and abnormal tissue together, so pathologists can compare the two, although that is not very significant, not a very important cause. And the necrotic tissue from the center will not be a great idea to take a biopsy from, because it will be yielding nothing. Once you've taken a biopsy, then you need to stage the disease. For that you need a contrast CT scan of head and neck. It will also show you about the lymph nodes. Can you do ultrasound for the lymph nodes? Yes, as I taught you, ultrasound is an extension of clinical examination. So we can do that. And that will establish the, if you understand it clearly, history of T, history of N, history of M. That is history. Examine for T and M. Investigate and treat for T and M. So for T, we've taken the history. For nodes, we'll take the history. For metastasis, we'll take the history. On examination, we'll look at what features I just discussed with you. Look for the cervical lymph nodes and stage the disease properly, because we'll need T and M for this. Investigation would be the same. For T, we have done an edge biopsy and we have done a contrast enhanced CT scan for, along with ultrasound, for head and neck, extent of the disease, involvement of mandible, and also for any other primary. Why am I talking about any other primary? There's something called as field cancerization, especially in those who are chewing tobacco. They can get anywhere the cancer along the epithelium that they're all sharing. So it is necessary to do that. Field cancerization will also be taken care of. Therefore, one more examination that is done is an office procedure, is indirect laryngoscopy, to look for any other lesion. And then of course you'll do X-ray chest. If there is a finding there to suspect metastasis, we'll do CT, otherwise we don't. And then we treat the patient. Treat for T. What do we do for T? We do what is called as wide local excision, which with R0 resection. So you take a wide local excision means what? Three-dimensional clearance with a margin of at least 1 centimeter, so that you get a clear margin. Add with that modified radical neck dissection, which all of you have answered very correctly. And modified radical neck dissection is a modification of radical neck dissection. Radical neck dissection is when you remove, I'm just drawing it for you, that's sternemastoid, that's clavicle. Level 1A is here, 1B is there, level 2 is here, 3 is here, and 4 is the lower 1/3. Upper 1/3, middle 1/3, lower 1/3. And in this is trapezius, this is sternemastoid. In the posterior triangle you have level 5. So 2, 3, 4. 1A, 1B, 2, 3, and 4. Easy to remember. Divide the sternemastoid in 3 parts. That's it. So if you remove all the levels plus 3 important structures, spinal accessory nerve, plus internal jugular vein, plus sternocleidomastoid muscle, we call it a radical neck dissection. This is not done frequently now. And if you preserve any of these structures, we call it modified radical neck dissection. If it is type 1, we have preserved spinal accessory nerve. Type 2, we have preserved plus internal jugular vein. Type 3, preserved all 3. And if you are doing bilateral neck dissection, you will have to preserve at least 1 IJV, which is otherwise it's not compatible with life. So neck dissection done. And when you dissect the angle, you'll have to reconstruct using some flap, which we'll discuss some other time. whatever you lost you have to reconstruct. Normally we'll use a forehead flap here, which is based on the superficial temporal artery.